Hello, everybody. Welcome to today's media call with the Association of State and Territorial Health Officials, or ASTHO. Thank you very much for your interest and for joining us. My name is Marcus Plesha. I'm the Chief Medical Officer of the Association of State and Territorial Officials. I'm going to be leading things off and then turning it over the conversation over to some of our state health officials. As you all know, FDA's announcements and the likely concurrence by the Advisory Council on Immunization Practices tomorrow opens the COVID-19 vaccine access up to 12 to 16-year-olds. This is an important opportunity to build further protection against the COVID virus in our communities. States are ready and able to vaccinate adolescents, and today we'll hear from our leadership on the front lines about how they will approach this population and some of the opportunities and challenges of vaccinating this new age cohort. However, to start with, as the primary care physician on the panel, I wanted to make just a couple of comments about the importance of making the vaccine available in primary care practices, where many parents can discuss any questions or concerns that they have with a trusted source. We know that offering vaccines in primary care practice is a very important and effective approach to increasing vaccination in this age group. And we know that primary care physicians are ready to help and are generally well-versed in how to have these conversations with their patients. There are also useful tools for physicians and how to counsel patients about vaccination and how to prepare their practices to prompt these discussions and increase vaccine acceptance. And states are making these materials available to their practices. It is most effective if primary care physicians can actually give the vaccine once they've had the discussion and the patient is ready to move forward. But moving relatively small volumes of vaccine, particularly the Pfizer vaccine, into these lower volume primary care settings can be challenging. And I think we'll hear more about some of those challenges from others on the panel today. So with that said, I'm going to kick off the conversation with some of our state health officials. Joining us are three state health officials. First up will be Dr. Nirav Shah, who's the ASTHO president and who's the director of the Maine Center for Disease Control and Prevention. Second up will be Dr. Umair A, who is the Secretary of Health at the Washington State Department of Health. And then third up will be Dr. Zink, who is ASTHO's president-elect and who is the Chief Medical Officer for the state of Alaska. So I'm going to turn it over now to Dr. Nirav Shah.
Great. Good morning and afternoon, everyone. Thank you, Marcus. Again, this is Dr. Nirav Shah. I am the ASTHO president and the director of the state of Maine's Center for Disease Control and Prevention, which is our public health department here in Maine. Thank you to all of our colleagues in the media for hopping on today and chatting with us. We've got a lot to talk about. I'm going to spend just 2 or 3 minutes setting the table by touching on 3 topics as it relates to now adolescent vaccination. The first is just generally what's happening at the national level from the bird's eye perspective from an ASTHO view. The second is to just talk a little bit about COVID-19 as it relates to children and part of the rationale for vaccination. And then third, start talking and highlighting how states are planning for the vaccine rollout and spotlighting any particular nuances that states are uncovering, both interesting and challenging. So let's start by just setting the table at the national level. Throughout the pandemic, states have been preparing and then rolling out vaccination for new and different groups of individuals as different states move through their vaccination processes. This newest group, adolescents, has nuances which we will certainly discuss, but I think my message here is that this is what your state's public health department does every single day. The planning and preparing that we have been working on as it relates to adolescents and are now rolling out is just what we've been doing throughout the pandemic, both before vaccination and now in the vaccination stage. We think it's important that kids, particularly adolescents, be vaccinated. Certainly there are reasons for their own health benefits why getting vaccinated is in their interest. Although COVID-19 is less severe in children, children can nevertheless be affected. There are children who can have longer-term symptoms that may persist after an infection with COVID-19, and just over 3,000 kids in the United States, I'm sorry, no, that number is a bit out of date, but several thousand kids in the United States have different from multisystem inflammatory syndrome, which can affect children and cause longer-term consequences unto itself. But I also think it's important that we make the case for vaccination of adolescents based not only on what is in the children's best interest, but also from a population health perspective. Vaccinating 12 to 15-year-olds, in addition to the 16 to 18 plus who are already authorized, helps us move one step closer to population level immunity. The more folks that we get vaccinated, the closer we are to that goal. Now, states have been planning and preparing for and are now rolling out their plans to vaccinate this group of adolescents. And along the way, we've discovered various nuances. One of them is that when we start talking about adolescents in particular, part of the planning that goes on is the need not just to talk to one group of people, adults, but also not just adults or parents, but also the kids themselves. So we have multiple audiences for the messages that we've had. Whereas up until now in the COVID vaccination front, much of our messaging has been direct to patients. But here, we have to speak not only to the patients, the adolescents, but also their parents and guardians to make the case simultaneously to both. It's just an added nuance. It's not any more difficult. It's just something we've got to think through and get right. We also have to have the conversation around hesitancy with parents. Recent surveys suggest a low percentage of parents who would consent to their kids getting vaccinated. That is among many reasons why primary care doctors, pediatricians, family medicine physicians who are on the front line speaking with parents and the kids themselves are so critical. The same approach that we've been taking with adult vaccinations applies here, which is to say some parents are extremely eager to get their kids vaccinated. Some parents, another group, are motivated by convenience. A third group has a lot of questions that they want answered first. And then a fourth group are right now not in favor of vaccinating. That's a group that's going to take more conversation to get on board. There are also related challenges that states are grappling with around things like consent. This is a different group and a group that necessarily needs parental consent. But similarly, states have been planning and preparing for this by having conversations with providers, educators, parents, etc., to get them ready to go through that consent process so their kids can get vaccinated. And then finally, the unique properties of the Pfizer vaccine introduce logistical challenges, whether because of the large lot size of 1,170 doses or the need for ultra-cold storage. But here again, these are the types of challenges that your state's health department is used to. Our state here in Maine is breaking up lots or trays of Pfizer so that smaller providers who may not need 1,100 doses, but maybe only 100 doses a week, can still be in the vaccinating game. Similarly, we're making sure that providers are not limited by not having an ultra-cold freezer. If they need a cool cube with dry ice, we can furnish that to them so they too can be vaccinating in their communities. You know, there's an urgency right now to taking advantage of the unifying framework that the academic school year provides. That's one reason we here in Maine are starting to work with getting those kids vaccinated before, as my colleague Dr. Zink likes to say, before they fly to the wind over the summer. So with that, again, thank you all for being on today. I look forward to the questions and the discussion. I'm going to turn it over to the other Dr. Shah who's joining us, Dr. Umair Shah, my colleague from Washington State.
Thanks, Nirav. Thanks, Dr. Shah, for the two Shahs on the same briefing is never easy, but it's fantastic to join you. And I just want to say it's great to be sandwiched between two incredible leaders in both Nirav and Dr. Zink, both in their roles as ASTHO leaders, but also in their respective roles in Maine and Alaska. And so it's great to be here. I just want to piggyback and just echo the comments that Nirav just made, which is really, at the end of the day, just the incredible enthusiasm by which all of us at the state level are really looking forward to this approval of the Pfizer vaccine for adolescents between the ages of 12 and 15. We know it's critical to reach those that are most at risk now from COVID-19, and that includes the older children, right? So the ones who are younger, tend to not have as much severity of illness, and yet the older, and in this case the adolescents, can still get sick and can still be impacted by COVID-19. And so the ability to be able to protect these individuals, these adolescents, is so critical to the work that we're doing. And I want to bring in the sort of personal side of this, which is as a physician, just as my two colleagues here, I also have 3 children. My wife and I have 3 kids, and the eldest of which is 11 years old, and she turns 12 years of age in September. And when she turns 12, we're going to be the first to make sure that she gets her vaccine as well for COVID-19. And certainly when our other 2 kids are eligible, they're 7 and 5 years of age, we certainly are going to make sure that they're also getting vaccinated, because we do believe, 1, that vaccines work, number 2, that vaccines are safe, and number 3, and I think most critical, is the vaccines are our pathway to moving forward and once and for all ending this pandemic. In the state of Washington, we administered close to 6 million doses of COVID vaccine, and that joins the 150 plus million doses that have been given across the country. And that's incredible progress when we think about what that has occurred in just a matter of 4 or 5 months. We are absolutely on a pathway to continuing to vaccinate across the state and across the country, but we cannot do it alone. We need more people to get vaccinated. In the state of Washington, there are approximately 378,000 kids who are between the ages of 12 and 15. And we know that that is going to be another group of individuals, now that they are eligible, that we certainly are going to be able to utilize to increase our overall percentage of coverage across the state of Washington. And I also think it's important to emphasize, and I know that Dr. Shah just mentioned this, but let me just also emphasize that we do believe that schools are safe for in-person learning now, before the summer begins, before school is let out. But absolutely adding the vaccine tool for 12 and 15-year-olds, 12 to 15-year-olds, also is going to allow us to assure that we have even safer ability to protect our kids in schools, especially as the fall months come back and the school year re-begins. So the announcement from the FDA and really the additional review processes and approvals that will happen across the federal system and the state system means that we are going to have more vaccine that's going to be eligible for more populations in our state in particular. We, just like Nirav mentioned, we're also working with our pediatric and other primary care providers, and we do want to make sure that adolescents can be vaccinated anywhere that already has Pfizer vaccine. But we're also working to get Pfizer vaccine to more pediatric and primary care providers, especially we want to make it easy for parents to want to be able to get information, talk to the provider, and also ultimately vaccinate their children. And Dr. Shah is absolutely right. This is the first time that we now are not just speaking to the individual who is getting vaccinated, but also the parent or guardian of the individual who is going to be eligible for vaccination, namely the adolescent child. And so it's absolutely critical that we gear our messages both for the parents and guardians as well as the adolescent who is going to be eligible. And our communications teams are working on that, as we know. The last thing I wanted to just mention is that the CDC said in a report just recently that older students and older children were also hit harder than younger children. And I do believe that that is why we really do need to emphasize this work, but also wanting to recognize that the CDC also showed that the severity of infection was more common amongst children who are Black, Latino, or have underlying health conditions. And so that equity lens is so critical to the work that we do. And we do know that there is vaccine demand across the state and the country, in the state of Washington and the country, but we also know that there has been some softening of that demand. We're hopeful that the message that we've been heeding to our public, which is don't hesitate, vaccinate, which is also, by the way, the same message we've been heeding to our providers, don't hesitate, vaccinate, helps people really overcome the concerns that they may have and obviously to make it easier so that where people go for their care or other modalities throughout the state of Washington, they can get the vaccine for their adolescents. So with that, I want to say thank you again to ASTHO and for our media partners. I want to thank Dr. Shah for his continued leadership and tireless efforts this past year. And now I'm going to turn it over to my colleague in the great state of Alaska, who I'm fantastically excited about joining as the next, he's going to be the next ASTHO president. So I'm really excited about that. So with that, Dr. Zink, I will turn it over to you.
Wow, great. Thank you so much. And to follow two amazing Shahs is a true honor. And thank you to all the media partners for being here as well. I too really share this immense excitement to being able to vaccinate those 12 through 15, being able to offer an incredibly safe and efficacious vaccine to a population that has really struggled this year. They have been asked to pivot. They have been asked to be resilient in so many challenging ways as they have been in and out of school, in and out of sports. Their lives have been really disrupted by this virus. And the quicker we can get them back to in-person, the quicker we can get them back to the sports, and the quicker we can put this pandemic behind us all, the better off we're going to be. So this is just a really exciting place and moment. I have two children as well, and my 16-year-old conversation the other night said, you know, Mom, being vaccinated is simply the best. Hugs and hanging out with friends who are fully vaccinated inside with no mask and not worrying about quarantining. I absolutely love it. And my 13-year-old pouted away and said, I can't wait for mine. And then soon after we found this note. So we too, as a family, are super excited, but more importantly for our country and our world as a whole to be able to have such a safe and effective tool. There are three things that I really wanted to hit in this conversation. The first one's kind of reasons about getting kids vaccinated. Two is the challenges for vaccinating those 12 to 15 that we're considering in Alaska and ways that we're thinking about addressing it. I think many of the reasons Dr. Shah mentioned earlier, and again, continue to message out to our parents and our kids. But as mentioned, kids have really struggled this year, and this is really our best chance at having a healthy, happy, in-person school, both the rest of this year as well as activities in the next year. But there's some different challenges with this age group. It's oftentimes a very collaborative joint decision-making or a decision made by their parents. So finding ways that we make sure that parents and kids at the same time can get that information, can address concerns, creating space within the pediatric office to do that, and making sure messaging is happening across the ground. We also see different challenges amongst this age group, things like infertility concerns, concerns about needle size, and trying to make it as fun and informative as we possibly can for both the parents and our young children moving forward. So some of the tools that we've been able to apply to our older age group, we can use in this younger age group, but we have to pivot and we have to really meet kids where they're at and their families where they're at, and make sure that we're providing trustworthy, honest, open information to them so they can make the decision to vaccinate to move forward. And we're thinking about ways that we're addressing this year. As I do talk about, the kids go to the winds here quickly. Because schools are the front line of public health. Many people know who the principal is, they know who the teacher is, and they don't know who the public health official is. And that's great. Schools play a pivotal role in the way that public health is addressed in many communities, be it food, access to internet, education, safe and healthy families, mental health, but also vaccine. And so our schools in Alaska get out quite early in May. So we have a very short time window for this. We're sending a big packet out to all of our parents and teachers that we have been preparing for some time. It goes out to superintendents today and out to parents tomorrow with everything from frequently asked questions to consent forms to a letter, really addressing many of the questions that we hear on a regular basis to encourage parents and kids to consider getting vaccinated moving forward. We also know that kids don't live in tiers and they live in families and they live in communities. And so what ways can we pivot the existing work that we have? So for example, many of our drive-through evening sites are being changed to Pfizer sites this weekend, just to really make sure that that parent and kid, you know, when mom's coming home from work or, you know, dad's finishing a shift, they can just drive through and make that as easy and convenient as possible. These kids live in families that are busy, and we want to make sure that it is easy and convenient as possible to be able to make the choice to get vaccinated. And then the third thing is just really making that space for questions. We understand that there's a lot of questions out there. We really encourage those questions. Again, really creating that space within primary care as well as the pediatric office, making sure that they've got the vaccine there so they can go ahead and give the vaccine if the family so chooses. Then also making sure that the youth are speaking to youth. So our Teen Media Institute here in Alaska has been doing a lot of messaging. We've been running a whole bunch of Zooms led by youth where they are kind of fielding questions from their peers and making sure that they're talking to each other and encouraging peers to share with peers on why they've chosen to get vaccinated. So with that, I will hand it back over, and we're just so excited to be at this spot. Thank you.
Great. Well, thank you very, very much, Dr. Shah, and Zink, for your perspective and also for your leadership. I think what the message we've heard is that states are ready and able to vaccinate adolescents, and you've heard some great strategies and approaches for how we will go about doing this. So with that, I'd like to turn it over to the operator who will queue us up with the first question.
If you would like to ask a question, please press *1 now on your telephone keypad. A voice prompt on your phone line will indicate when your line is live and open. Please state your name and media outlet before asking your question. If you would like to remove yourself from the queue, you may do so by pressing *2. Again, to ask a question, you may do so by pressing *1. We will take our first question. Caller, please state your name and media outlet.
This is Angelica Levito from Bloomberg News. Thanks for taking my question. Can you explain a little bit what the consent process looks like, and specifically for kids, how that varies from the current consent process for adults?
Sure. This is Nirav from Maine. I can start that. For adults, so let me start here. It is structurally the same, right? The notion of informed consent applies with equal force to adults as it does with adolescents. But with adolescents, it varies in a few manners. First is, at least in Maine, we do not require that a parent be on site and present during the vaccination itself. So a parent could sign a form, say, for example, allowing their adolescent to be vaccinated at a school-based clinic, which, as Dr. Zink noted, are really instrumental to our efforts. They don't need to be on site for that. We're also allowing in Maine verbal consent to be given. So if a 13-year-old happens to find their way to a vaccination site and would like to get vaccinated, they can get the parent on the line, and the parent can give verbal consent over the phone without necessarily needing to do all the forms ahead of time. All of these things are doable and in place because we've taken the time before the authorization for adolescents to get everything in place ahead of time.
And this is Umair Shah from Washington. I would just echo what Nirav just said and just add in the fact that, again, what the biggest change here is the addition of the parental consent, meaning that you don't have the actual individual who's getting vaccinated be the one that's providing the consent alone, that it's really with the parent or guardian as part of that. So we've been working on what that looks like so that we have that ability to also not make that a hindrance or an impediment for adolescents to get vaccinated. So again, echoing what he said, but just adding that additional piece that, as he said, rightfully so, fundamentally it's very similar.
The only thing I would add from Alaska is that it's not a monolithic process. So while consent is needed, we see a variety from our public health areas to the pediatrician's office in what they want. So some of the pediatrician's offices really want to have that parent in there and don't want to accept a written one. Some are willing to. So we see a great deal of variety amongst our sites in Alaska.
Great. Operator, we're ready for the next question.
Thank you. Your line is live. Please state your name and media outlet.
Hi, this is Max Baer from CBS News. Just given this amended authorization, I just wanted to take all of your temperatures on whether vaccinations should be mandated at schools in your state and public schools in your state, given that, in August, it might still, at least the Pfizer vaccine might still be under emergency use and won't have full approval until potentially September or sometime.
Hey, Max, I can start. This is Nirav. Right now, so in Maine, last year, we did remove both religious and philosophical exemptions here in Maine, becoming the third state to do so. We've started thinking about what the implications are for COVID as it relates to that framework. Haven't made any conclusions or final decisions yet, partly because, as you noted, it's still under EUA, although Pfizer, as folks are aware, has applied for a full BUA, not for the 12 to 15 population, but starting with the 16 and up, and as their CEO noted, planning to move on a rolling basis to other populations for full BLA approval. I think that's going to be critical, both from a regulatory perspective as well as from just a psychological or confidence perspective. As Dr. Zink noted, there are still questions out there, and one of the questions that we continue to get is, shouldn't I wait until this is fully vetted by the FDA with those 6 months of data? So right now, that's how we're thinking about this, but I welcome input from my colleagues as well.
Yeah, this is Umair A. Let me just add in from the Washington perspective. As you may well know, in May of 2019, the Washington State Legislature passed a bill that removed the personal and philosophical options to exempt children from the MMR vaccine required for school and child care entry. And that was really because of the measles outbreak that we had in the early part of 2019. And so I do think that there is really some of those changes that have occurred for other kinds of vaccines. I think the reality here for COVID vaccine is that, one, we're trying to do everything we can, and I think this is shared by state colleagues across the country, other secretaries of health, is that our number one ability to get people to get vaccinated or to take vaccine is for them to be encouraged to do so, to be incentivized to do so, to do everything we can to make the vaccine choice the easy choice. We're trying to do everything we can to remove barriers for hesitancy, barriers for access, barriers for concerns like language barriers or cultural barriers or anything else that really comes across the system. But I do think that as we get into the requirements place, we do have, for example, in higher education, University of Washington and Washington State University that have indicated they are going to require vaccines for COVID vaccine for kids to come back to school. I do think that is something that's increasingly being looked at. The one thing that all of us recognize is that COVID vaccine, unfortunately, has the whole concept has become politicized in a way that other vaccines have not in the past, or at least not in recent memory. And so I do think that there are some things to work through. And certainly, again, we want to make sure we're doing everything we can to encourage and incentivize as the first option.
And then this is Dr. Zink from Alaska. The state of Alaska has no plans to mandate a vaccine in general. We don't usually mandate. We have very few even COVID mandates and have not had many in place for a very long time at this point. We really try to just educate Alaskans to make decisions that are best for their health. Currently with education, we have over 10 boroughs have over 70% of eligible people 16 and above are vaccinated. So at this time, no plans for mandating vaccine at the state of Alaska. Thanks.
Operator, next question, please. Operator, we're ready for the next question, please.
And we'll take our next question. Take our next question from Pian Huang with NPR.
Hi, thanks for taking my question. One of the challenges I've heard about giving the vaccine out in doctors' offices has been a fear of wasted doses. And I've heard of doctors who don't want to open a vial if they can't give all the doses out. Is more waste a reality in this next phase? And how much waste is acceptable given that there's so much need for vaccines around the world?
I can go ahead and start that, Pin. You're right. One of the things that our colleagues across the states have been discussing with officials at the CDC as well as at the White House as recently as yesterday is the need for smaller packaging to accommodate smaller venues of administration. Right now, the Pfizer comes in trays of 1,170, and even breaking it up into smaller lot sizes takes a fair amount of effort by somebody to break it up and redistribute it. We understand that later this month, the lot size will be going down to 450, but even for a doctor's office, a solo practitioner, for example, that's a lot of vaccine to have on hand at any one time. The other piece of that is the number of doses per vial, to the wastage point that you note. Another thing that ASTHO has pressed CDC and our federal colleagues for is, for example, single-use or single-dose vials or single-dose syringes. So that reduces the likelihood of any waste. That being said, wasted doses are a phenomenon now that, from an ethical as well as from an operational perspective, states and providers are having to grapple with. I don't have an answer to your question. I mean, I think it goes on two extremes. If you have a vial with 6 doses in it, and there are 5 people waiting for a vaccine, thus you would only have 1 wasted dose, that's one thing. If you only have 1 person and thus 5 wasted doses, that's another calculus. I'm not sure as a country we've really had that conversation yet, given, as you know, there are places around the globe are in dire need of vaccine.
And this is Dr. Zink. I really appreciate this question, and a state larger than Texas, Montana, and California combined with a small population, this comes up all the time. Like Maine, we have been in the process of redistributing vaccine. Sometimes it's just 1 vial or 2 or 3 vials to be able to get out. So we spend a lot of time as a public health department doing lots of redistribution across the state because of the shipping size, and are looking forward to smaller ones. And then, as mentioned, also the component of just how many doses. The other thing that I would add to Dr. Shah's comment is the distance. I was recently in Hyder. There were 2 people left to get vaccinated, and had to make the decision: do I open 1 vial and potentially waste 4, or leave 2 people stranded there an hour and a half float plane away and not give them vaccinated? So distance, the next time they'll be able to access vaccine, all also play a role into that. We also in Alaska are setting up in our more urban areas ways to pick up extra doses from the clinics at the end of the day and take them to our mass vaccine sites to be able to use them at the end of the day when they have a few hours left. So we're trying to create better systems to kind of work around this fact that you may have a few doses here and a few doses there at different clinics at the end of the day, but not have them go to waste, because we really, this is a precious resource, and we want to make sure that we are as responsible as we possibly can with the doses. Thank you.
And this is Umair Shah in Washington. What I want to just add is that early on in the vaccine process, we actually put a requirement in place for our providers to use 95% of their vaccine supply within 7 days. And we put that state requirement in because we were really concerned at that time that we had vaccine that was coming into the state, and providers were being careful with, what they were ordering, but also how they were administering. And so we were actually seeing some increase in leftover vaccine at that time. So we put this requirement in place, and just on Friday of this past week, on the 7th of May, we then removed the requirement to use the 95% of vaccine supply within 7 days. And we removed it for a few reasons, but essentially because we wanted to assure that vaccine is on hand to take advantage of any opportunities to administer to those who are coming into a provider's office or another interaction, for example, a pharmacy or a long-term care facility or even somewhere else. We want to make sure that there is adequate stock of vaccine, and we also wanted to make sure that we were encouraging providers to check their patients' vaccination status. We do know that healthcare providers, particularly physicians, but nurses and all sorts of other healthcare providers, are absolutely critical to convincing and helping individuals understand and recognize the importance of vaccination. And so we wanted to make sure that at every opportunity the provider was checking the vaccine status for COVID-19 for their patient during any regularly scheduled appointments, and then offering and administering the vaccine to anyone who's not been vaccinated yet. And that also they were offering walk-in appointments, particularly for BIPOC community settings. And so it was so critical for us not to have this 95% requirement anymore, because we were hearing from our providers that they were trying to still be very careful on utilization and administration of that vaccine. So by removing the requirement, it is now opened up so that providers are now more focused on how to get vaccine into the arms of Washingtonians rather than being concerned about a 95% requirement. And so that's really been something that we are really monitoring. And I think Dr. Zink, Dr. Shah, and myself will be the first to admit that throughout this vaccine process, we've had to evolve our strategies as the needs on the ground or the situation on the ground has evolved as well. And so I think it's really important for us to continue to do that.
Yeah, and this is Marcus Plush. I just wanted to add one thing to make sure everybody is aware that up until now, the waste rates for COVID vaccine have been extremely small. Minuscule is the number we keep hearing from CDC. So, up until now, this has not been a problem, and it'll just be a matter of titrating the doses as we move out into these new settings. Operator, if we could have the next question, please.
Thank you. Again, please state your name and media outlet.
Hey, I'm not sure if this is, operator, is my line open?
Yes, ma'am.
We can hear you, yes.
Hey, guys. Hey, it's Ashley with ABC News. You mentioned doing vaccinations in schools, and I'm wondering if you could elaborate a little bit more on that. Obviously, we've already seen with vaccinations across the country with adults that things vary state to state a lot, and I'm assuming that's going to be the case with teens as we go into that. So I'm wondering what you're seeing in your respective states for efforts in school and beyond.
You can go in reverse order. Dr. Zink, you want to start?
Sure, I'd be happy to. So we have 52 independent school boroughs and districts here in the state, and so we see a lot of variety. So we have many that saw when the ACIP meeting got scheduled, and they booked in-person vaccine clinics in their schools for like Thursday, Friday, anticipating this kind of announcement and approval. So some are set and ready to go. They are getting consents by parents and then going ahead and offering vaccine in the area. Some have done, they don't have schools on Friday for some of the schools, and so they are offering big vaccine sites on Friday to be able to make that happen. And then, as mentioned, many are pivoting to using their drive-in sites to be able to make those happen for both teens as well as adults. We are also seeing one of our really big school districts, they get out this Thursday, so we are in a very tight time crunch for them. And so there's been talk about having a celebratory for the end of the year get together in a week where they're able to offer a vaccine. So it really depends on the school district and when they're getting out. But we're seeing everything from in person in the schools and the cafeterias to right afterwards, still using the local sites. But it's very varied across the state. Thanks.
Yeah, and this is Umair Shah. Just to add, in Washington, very similar is that you've got schools that are reviewing how they can be hubs for students to get their COVID vaccine. Many school districts are planning clinics. We know that some are starting in really in the near future, in the next several days to weeks. But then others are saying they're going to be starting in June. And really, there also have been talks with pharmacies about having optional clinics for students. And so there's really been a lot of movement. And as Dr. Zink mentioned, it really is heterogeneity on how schools are going to be utilizing or being able to offer vaccine. Now, at the same time, we also have a lot of parents who have been very excited about this, and they're trying to get their children vaccinated as well. And then we are hearing some anecdotal information about parents, especially who have older children who are interested, for example, in traveling over the summer months, and they want to go ahead and get their kids vaccinated as well. Obviously, it doesn't apply for the youngest, but for 12 and older, and get them vaccinated so that they're equally protected as they make their summer travel plans.
And finally, here in Maine, what's happening in Alaska and Washington closely mirrors what we're doing here. Our approach for this newest group of adolescents really utilizes, in big picture terms, 4 different types of venues, one of which are the existing large-scale sites, which are still operational. The second are the existing pharmacies of different types. This is Walgreens and CVS. The third, which we've touched upon, are primary care offices for those parents who have a lot of questions and would like that more personal touch. And then the fourth is going directly into schools. we're still in session here in Maine in the school system. And so one of the relationships that we've cultivated throughout the vaccination process is with different groups of vaccinators who can go on site, be they independent pharmacists, EMS groups, groups of that nature, who can pick up and move into a school gym and set up vaccination clinics there. As Dr. Zink noted, we've encouraged groups to plan and prepare for that in the event that the vaccine was authorized for adolescents, which it is now. So starting later this week and into next week, a number of schools across Maine will be hosting vaccination clinics, not just for the 12 to 15, but for 12 and over.
Operator, if we could have the next question, please.
We'll now take our next question. Caller, your line is live. Please state your name and media outlet.
Hi, my name is Alex Roof. I'm with BGov. I wanted to ask, you guys talked a little bit about primary care physicians, and I wanted to ask, do you have a sense of how many pediatricians' offices are currently sort of in these programs? Do you have like relationships with? And I'm just kind of curious if, I know like 12 to 15, a lot of those kids kind of move out from pediatricians, but I'm just kind of curious as to the question of, like what's the existing relationship that you guys have sort of with the pediatricians in your state? Is this going from, zero to trying to catch them all so they can, know where to order and get these things together and have this together? Or is this, something you guys already have an existing sort of stock of? Could you talk me through that?
Sure, I can kick that off. This is Nirav from Maine. Pediatricians' offices and family practitioners' offices are perhaps our most well-known group of stakeholders from a state health department vaccine program perspective, and that's because of the presence of the Vaccines for Children program, a federal program that provides vaccines for children. And pediatrics and family medicine are two of the groups that we support the most. And so they are well versed in how to order vaccine, what the various storage requirements are, how to administer it, how to log that administration in our state vaccination registry, so on and so forth. I don't mean to suggest that every single pediatrician and family medicine practice in the state of Maine is offering Pfizer vaccine today. That's not the case. We've still got to make sure they've got the logistics support and the cold storage support. But from an ordering and operational perspective, we have a great relationship with the pediatrics community.
And this is Dr. Zink. I would completely echo that. Our pediatricians and our family practice docs are our vaccine experts. They're the ones who have conversations with families on a regular basis about vaccines. Not only that, but also are registered and part of our vaccine IT system. They're used to storage, they're used to handling. And in fact, when vaccines first came into the state of Alaska, many of our pediatric offices were offering vaccines to adults throughout the time because they were so well versed in vaccines as well as vaccine distribution. So they have been an integral part of our response since we've been able to have vaccines in December, and they have stood up and are excited to offer it to a patient population that they're much more familiar with. I think the group that we continue to really struggle to figure out how to reach is kind of that 20 to 40-year-old age group, the group that doesn't normally have as much of a long-standing relationship with a primary care provider or a pediatrician. And continuing to try to make sure that vaccines are offered to those parents at the pediatrician's offices, because this may be a way to make sure that the whole family gets vaccinated when they bring the kid in, rather than just kind of, again, just each individual tier and each individual group. So we're hoping that this not only gets our 12 to 15-year-olds vaccinated, but we'll see an uptake in the 20 to 30-year-olds who are bringing their kiddos in for these appointments. Thanks.
Yeah, this is Umair from Washington. I just want to just add the numbers for us are, we have about 700 pediatric care providers who are enrolled as COVID vaccine providers. It's about just under half of our providers. Now we also have some of those who are pediatric care providers who give childhood vaccines who are not enrolled necessarily as COVID vaccine providers, but in addition to the 700, we have an additional 400 that are vaccine providers that are in our childhood immunization program but are not COVID vaccine providers currently. So that's really where we are right now, is 700. So just under half are pediatric. Now that does include at times family practice, and so there may be some overlap there. But I think the key message that both Dr. Shah and Dr. Zink highlighted here is the one for us in Washington, which is initially when the vaccine was rolled out, obviously we were trying to get to healthcare providers, long-term care facility residents and staff, and so it was really very much hospital and medical system based and centric. Now, as we move into the latter stages or the latest stages of this vaccination process, it's really about pharmacies, it's about community clinics, it's about doctors' offices, it's about really boots on the ground close to where people live, learn, work, worship, and play. So we're really trying to do whatever we can to outreach and have vaccine available closer to home, if you will. And so that really means that the medical providers are absolutely critical to the work. And we really want to see that emphasized not just for pediatrics and family practice, but also hospitals and emergency departments that, when somebody comes in with a broken arm, that they're also asked about vaccine status and they're also offered the vaccine if they have not gotten it already. So again, all the tools that we're trying to utilize across the country.
Brett, if we could have the next question, please.
Participant, your line is live. Please state your name and media outlet.
Hi, it's Lena Sun at the Washington Post. I wondered if you could just be a little bit more specific in the logistics when the CDC signs off on this tomorrow. Are there plans to redistribute some of the Pfizer vaccine, or are you going to stick with the providers, the distribution venues that you have now?
I can go ahead and start, Lena. Hey, this is Nirav. Good to hear your voice.
Yeah.
Let me just make sure. So could you just clarify? So is your question, are we activating new vaccination venues, or are we going to stick with the structure that we've got in place? Is that the gist of your question?
Yeah, I mean, because of the storage requirements and because of the lot size, right, the pharmacies are going to already have in place the refrigeration and storage to do that. The large hospitals already have that. It's the pediatric practices that often don't have that, the ability to do 450 doses, and you have to break it up more. I didn't know if the focus is going to be continuing to get the Pfizer vaccine to those places that are already pushing it out now, or to switch it up a little bit.
Yep. I'll start and then welcome my colleagues. I'll just be really quick. Initially, Lena, given that there is urgency both on the part of parents and adolescents to get vaccinated, as well as vaccinators to start getting shots in arms, for the first days, maybe even the first week or so, the focus of our strategy, the mainstay, will be utilizing existing sites and equipping them with all the Pfizer that they need. But for weeks now, we've been working with larger pediatrics and family practice groups in Maine to get them to estimate for us how much Pfizer they could be administering to adolescents and teens every single week. So not this week, but next week, we'll be breaking up trays of Pfizer for those pediatrics offices and then putting that into cool cubes with dry ice and getting that out to the pediatrics practices that we've been working with who want that. The other element that we're doing, Lena, is activating sites that may have, in rural parts of Maine, may have a couple of weeks ago sort of said, okay, we've vaccinated all the adults who desire a vaccine, but now with the addition of adolescents, they would like to reactivate their locations. So in many places in northern and western Maine, they've requested 300 or 400 doses for their hospital system to vaccinate kids. What we've done is either break those up in our warehouse and send them out, or alternatively, ask 3 or 4 regional hospitals to come together and split up a tray amongst themselves. And we've seen great uptake with those, what I call a consortium model, where we send one tray to an agglomeration of 3 or 4 regional hospitals, and they split it up and use the doses among themselves. So in northern Maine and western Maine, we're doing that actually this week.
Thank you.
This is Dr. Zink. We, as mentioned before, have been in the redistribution process since the beginning. So that's been a part of it. I would say that 2 months ago, we switched from allocating vaccine for census and borough region to asking every single public health region to give us a plan on their plan monthly on how they were going to increase vaccine rates and what that was going to look like. As part of this month's plan, we asked them to all plan for this age group and what their plans were and their estimates for doses so that we can make sure that they had it kind of in place, ready to go, ready to order, or ready to be, transferred, as Dr. Shah just mentioned, to maybe one hub site that they can then distribute afterwards. So it looks very different across the state, but they have each planned for this moment, and now it's just time to execute it.
Yeah, and this is Umair Shah in Washington. Lena, great to hear your voice as well. I would say that it's an all-in approach, and just as you heard from my colleagues, there's a heterogeneous approach as well. That it doesn't work in every community, every school the same way. And so in the case of pediatricians or pharmacies or in school districts, every one of them have heterogeneous ways because of local needs. And so I think one of the key messages at the state level is that we want to do everything we can to support vaccine efforts across our respective states, but recognizing that the local health departments, partners, tribal vaccine partners, and all sorts of other partners that are on the ground in the private sector, we want to do everything we can to support their work, including whether those efforts are different in certain communities compared to other communities for various reasons. And so we really want to continue to pivot across the system. And then finally, just to add that we do recognize the importance of all channels, all in approach, so that we are going to continue to utilize the traditional channels we've used, but also now really moving forward with a lot of outreach and really individual efforts to get into communities so we can also help support the efforts that are happening there to overcome hesitancy or softening of demand.
Great. Operator, can we have the next question, please?
Participant, your line is live. Please state your name and media outlet.
Hi there, this is Hannah Ferfaro from the Seattle Times. This is a question for Dr. Umair Shah. I'm curious if you can just talk a little bit more about how schools might be working with DOH or other local public health partners to roll out vaccines. I know that Lena's question was sort of getting at this, and another reporter asked something similar, but then talking with school districts, it sounds like many of them don't really have that vaccine drive dates yet, and I'm wondering what efforts DOH is doing at this point to help them get those rolling as soon as possible.
Yeah, no, thanks for that question, and great to hear somebody local close to home here. As you know, that there's a state agency that also oversees the work that happens from the superintendent standpoint, and so we're working at a state level, with our state colleagues. But you're right, there are a lot of school districts, I think, as I just mentioned with Nina's question, the heterogeneity. And so we're also working through and alongside our local health partners that are also working with those local school districts. And so it's a combination of what DOH is providing overall with the support. And then certainly, if a school district reaches out to us, our first inclination is to make sure to connect them with their local partner if we're aware of something that's happening, and where we see that there is not something happening but the need is there or the zest is there to be able to do this, then for our own team to be able to then work through that navigate that system or work through that challenge and then work with that independent school district ourselves. And so there are just a number of things that we're doing, but right now it's really working a lot with our partners at the state level as well as in the local community.
Great. Operator, can we have the next question, please?
Caller, your line is live. Please state your name and media outlet.
Hi, this is Candace Choi from the AP. Dr. Shah, you mentioned the different options for consent, the verbal being on site or the phone option. Are all of those options going to be consistent across the state, or as Dr. Zink noted, could the consent requirement differ based on the location?
Sure, thank you. What I described is sort of the floor, not the ceiling. Those are the bare minimums for consent to be legally valid. But certainly in some locations, there will be much more of a conversation that is had, which is tantamount to consent. As Dr. Zink noted, in the doctor's office, in the primary care pediatrician's office, that's a conversation that will be a lot more in depth. What I was referring to is really just the bare minima that need to exist for consent to match what the state health department guidelines are. Does that answer your question?
Yes, in part it does. And then my other part of the question was, is there anything the child has to do to as part of this process, or is it all just the consent with the guardian?
Well, my other two colleagues are more clinically based, but my understanding is generally it's the consent of the parent, but the assent of the child. So the child has to be, the adolescent's got to be bought into the process as well. Although they are, again, lawyerly, they're not providing the consent on the document. That's the parent. You want to have an alliance with the child as well to make sure that they're on board with getting vaccinated as well. And my understanding is that that's referred to as assent of the child. But again, my other two colleagues are closer to the clinical side of this than I am, so I'll let them weigh in.
Yeah, this is Umair, and Nirav, you're right. I think the other piece that is very much a part of this is the concept of mature minor, and so we're also working with legal in the state of Washington to really look at all the consent requirements or anything else that opens up additional avenues for vaccination. Again, I think the key message that the three of us are wanting to make sure that we get across is the importance of removing any of the barriers that are there. And so if the barrier is because of something that's legal, we want to do everything we can to review it. But as clinically, Nirav is correct when it comes to how we're treating consent across the system, because we certainly know that we want to make sure consent is there and that it's careful and it's methodical. At the same time, we also don't want it to be a barrier.
Dr. Zink, do you have anything to add?
No, I mean, I would agree with all of that. And I was just going to add the component of the consent for the minor. I also think that we've seen in other public health measures where children can sometimes be really the advocate for health and bring their parents along. Everything from, Mom, I really don't want you to smoke, and parents are receptive to that. We see many cases where younger kids didn't want to have to quarantine anymore after someone on their sports team became positive. And so they got vaccinated prior to their parents. And so we really see messaging and having that communication to both youth and their parents as important, and we need to make sure their voice is not left out. But the legal aspect, I would totally agree with what Dr. Shah said. Thanks.
Great. Well, we have reached the top of the hour and the end of our scheduled time. So I'd like to, first of all, start off by, again, thanking our state health officials, Dr. Nirav Shah, Dr. Umair Shah, and Dr. Ann Zink for taking the time to give a little bit of perspective about how we're going to take on this new opportunity in COVID-19 vaccination. And I think that the message that we come away is that states are ready and able to vaccinate adolescents. And you certainly heard a number of approaches and settings for how we'll go about building on our ongoing success vaccinating the U.S. public. I'm sorry if others had questions that we didn't get to, but please, if you do have additional follow-up questions, you can reach out to us, to Jane Esworthy, who can be reached. Jane Esworthy is the director of our public relations program, and she can be reached at media@astho.org. Again, thank you very much for your interest and for attending our press conference today, and take care.